Hi, hope am I audible?
Yes, Madhuri.
Can you give a confirmation? Okay. Thank you so much. Good morning, everyone. On behalf of the AAPV Hyderabad local chapter, we'll wait for a couple of minutes before starting today's session to ensure maximum participation. Okay. Uh, we'll begin shortly. Thank you for your patience. Meantime, feel free to say hello in the chat box and let us know where you are joining from and what is your interested topic to learn in our going forward webinars. This webinar, we selected the topic based on your previous interest. If you share the topic details on which you have more questions or need clarification, we will try to arrange the session on the to explain the guidelines to you. I see many of you responding and actively engaging already. So this is amazing, guys. So this kind of energy makes today's session even more exciting. And majority of the went from we reached the maximum, uh, reached almost video 800. Let's start the session. Good morning, everyone. A very warm welcome to all of you today. On behalf of the APC, We are delighted to have you. Thank you for taking time out of your busy schedule to join the session. Before we move on, let me take a moment to introduce myself. Myself, my name is Srimadri Katoju, and I bring over 13 plus years of experience in the healthcare industry. I am honored to share that I have been part of the APC Hyderabad local chapter the past 5 years, serving as an educational officer. Being associated with APC has been a truly enriching experience for me, and it is allowing me to contribute to professional education, knowledge sharing, and skill enhancement within our coding and compliance community. I strongly believe that platforms like these webinars play a crucial role in helping us stay updated with industry changes, experienced professionals, strengthen our confidence, and that takes us over this. Along with me, I do have Srinivas here. Srinivas, he's our associate vice president of Hyderabad local chapter. Srinivas, can you introduce his maybe he's some kind of issues? Uh, we do have this start.
Madhuri, your voice is breaking and there is no clarity. So,
Is my voice clear now, Harish?
Yes, ma'am.
yeah, now it is okay. Yeah,
Okay. So, Harish, hello, am I audible?
Yes, ma'am. Yes, please.
Okay. So, let me start again. My name is Srimadri, and I am honored to share that I have been part of the AAPC Hyderabad local chapter for the past 5 years. Along with me, I do have Harish Srinivas Prasad here. As we all know, the healthcare industry is constantly evolving. Coding guidelines, compliance requirements, and quality expectations continue to change, and staying current has become more important than ever. Webinars like today's are not just about listening, they are about learning, engaging, and applying. I encourage everyone to make the best use of this session by actively listening, posting your questions in the Q&A or chat box, taking notes on the key takeaways. Let's make this session interactive and valuable for everyone attending. Whether you are joining as a certified professional coder or an aspiring coder, an auditor, leader, or someone exploring growth opportunities in healthcare, today's session is designed with you in mind. So, without further delay, let me now uh, introduce our speaker for today. She is Rupanshi. Rupanshi comes with 11 years of experience in the healthcare industry, and she is certified professional, bringing strong expertise and practical knowledge to today's session. With her extensive experience, she has worked closely with real-time healthcare scenarios, helping professionals navigate complexities with clarity and confidence. Her ability to break down concepts and share practical insights makes her sessions both informative and impactful. Today's topic is principles and practices in OB-GYN coding is highly relevant and aligned with the current needs of our industry as requested by you in our previous session. And we are confident that this session will provide valuable learnings you can apply directly in your day-to-day work. Before we start, please keep your microphones on mute. Feel free to drop off your Q&A questions in the chat box or Q&A session. We will try to address as many questions as possible during or at the end of the session. Without further delay, please join me giving a virtual round of applause and a warm APC Hyderabad welcome to our speaker. Rupanshi, over to you.
Thank you, Madhuri. Hello, good morning, all. Very good morning. My name is Rupanshi Saxena. I have total of 11 years of experience in medical coding. I am currently working in Eritis as an lead trainer. My core specialities are emergency coding, inpatient coding, outpatient coding. I also deal with ambulance coding, denial, and radiology. If I talk about my education background, so I have done AAPC certification from CPC certification from AAPC. I have done masters and graduation in computer science. Recently, I have completed a certification from AAPC, that is in AI in medical billing and coding. So now moving on to my topic. My screen is visible.
Yes, Rupanshi. Yeah.
Okay. Okay. So here are a few etiquettes we have to follow during the entire session. Please ensure no distractions should be there so that we can take away all the important and genuine contents. Be attentive during the session. This session is being recorded. Question and answer round at the end of the session will be there so that your queries can be answered. You can also submit your queries in the chat box. So the key objective for today is the introduction, what OB-GYN coding is, and then the understanding of the CPT for the OB services. Then I will cover what are the ICD-10 codes which are being followed for the OB services. And after that, we have master global OB package and exclusion. Then after, how to correct code the medical records and the complex scenario. I will provide the case studies and we will go through that. And at the end, how the documentation should be improved to support the compliant coding and billing. So here are the overview of the obstetric coding. Denial resolution involves documentation with coding and billing, not, not just billing alone. CPT procedure must be aligned with the ICD diagnosis so that our medical necessity is being satisfied and no more denial rates, means basically denial rates get reduced. Coding requirements differ across antepartum, delivery, and the postpartum. Most of you might be thinking, what are these terms? So later on in this session, I will be explaining that as well. Next, we have global OB packages apply only when peer criteria are fully met. Then we have the trimester and the week of gestation must be accurately coded and documented. At the end, pregnancy outcomes, complications, and fetal details are mandatory for the compliance coding. So here is the introduction to OB and gynae coding. So OB and GYN coding refers to medical coding specialty that focus basically on the obstetric and the gynecology services. It involves assigning accurate ICD-10 diagnosis code, CPT or the HCPCS code, procedure codes, and sometimes modifier for the services related to women's reproductive health, pregnancy, childbirth, and the postpartum care. OB-GYN coding is considered a highly specialized area because it combines medical condition, surgical procedure, time-based and global billing rules, and the last is the trimester-specific and episode-based coding. So here are what are the visits which are being applied to the OB-GYN coding. So office visit are there, prenatal checkups are there, gynecologic exams are there, then we have diagnostic tests, minor procedures are also there, and again after delivery, follow-up care is also there. Moving on to the terms related to OB and gynae coding. First is the gravida. So what does gravida means? All of you please hear these terms very keenly, because in later on the session I will be using them as well. So gravida is the total number of times a woman has been pregnant. Second is the para, number of pregnancies carried beyond viability. Abortion. Abortion, pregnancy lost before viability. It can be spontaneous or the induced. Next one is the antepartum period, that is before delivery. Intrapartum period, during labor and the delivery. And the last one is the postpartum period after delivery, that covers up to 6 weeks duration. Okay, moving on to the next slide. Next is your EDD, that is estimated due date. Global OB packages. There are many OB packages globally. So over here, what it means, global means includes antepartum, delivery, and the postpartum services. In that particular global package, all these three will be included. Next is LMP, last menstrual period. GTPL. Next is basically GTPL is the gravida term preterm abortion living. NSVD, normal spontaneous vaginal delivery. Then is C-section, which is very common, that is cesarean delivery. So for the vaginal delivery, we have two types of delivery, which one is forceps vaginal delivery and the episiotomy vaginal delivery. What does this really means? Forceps vaginal delivery, a spoon shaped instrument is being used, that is known as forceps, applies to the baby head. Basically what it does, it basically take out the baby through the birth canal, and it helps in the delivery. So forceps applied to the baby head, assisted type delivery it is known, and it helps to deliver the baby. Next is episiotomy delivery, which is a small incision is being made. Next, to instrument, no instrument on the baby is done. It is a small incision is being made, and from there the birth canal is widened up and the delivery is done. Basically, it enlarges the vaginal opening. So here are the global OBCPTs. 59400, which is vaginal delivery routine. 59510, that is cesarean delivery. 59610, that is vaginal birth after cesarean. Next is 59618. So 59400. This CPT is basically for the routine obstetric care, including antepartum care, vaginal delivery with or without episiotomy and forceps, and also includes postpartum care. So, antepartum care. What does it mean? As I have already told, what does antepartum means? Antepartum is basically before delivery time. So, it includes antepartum care, which is before delivery, then vaginal delivery, and then the postpartum services. So, in simple terms, if we understand, OB-GYN use this single code to bill for multiple obstetric care related services throughout the patient pregnancy. Typically, global maternity care starts with routine prenatal visit during the 8th to 10th week of pregnancy. As briefly I have introduced in the CPT, it is a global services. It includes all the three. Hence, vaginal delivery of infant and placenta, episiotomy, if performed, it is also included. Repair of first or second degree laceration, postpartum care, that is hospital and office visit, up to how long? Up to 6 weeks. Now, when we need not to report 59400. So, all components are not provided by the same physician. So, as this is a global package CPD, we need to have all the components, that is antepartum, vaginal delivery, and the postpartum. If any one of is missing, then we are not going to code 59400. Or if care is being transferred in or out, cesarean delivery is performed in between, or only partial OB care is rendered. In those cases, we are not supposed to bill 59400. Here comes the case study or the example we can say for 59400 so that you can have a clear idea of 59400 CPT. A 25-year-old woman begins her prenatal care at the 8th week of pregnancy. Hence, our patient sees her OB-GYN every 4 weeks until 32 week, then every 2 weeks until 36 week, and weekly thereafter until delivery. So what happens during each visit? Obviously, she will visit to the provider. What provider do? He or she will evaluate her condition, check for vitals, signs, monitors the baby growth, and make necessary medical decision. At the 39th week, the provider helps the patient give birth vaginally after spontaneous labor. The same OB-GYN then provides the postpartum care for the 6 weeks. Now, this is the entire scenario where we can code 59400, which will cover all the three services. First one is antepartum, then the vaginal delivery, and the postpartum services. Hope this CPT is clear to everyone. Okay, so now I am moving on to the poll question for this particular CPT. So when should CPT 59400 be used? When only delivery is provided, when antepartum delivery. Hello. Second option is when antepartum delivery and postpartum care are provided by the same provider or the group. Third, when fewer than 4.
Rupanji,
Yes.
give them the time. Let them answer. Then we will explain
Okay.
this.
So, okay, they are able. You are able to see the entire option. Second one.
Yeah.
Okay.
Yes.
Okay. Thank you.
Yes, we do see 17% of recruitment for this post. I request everyone to be attentive and respond to our questions. Rupanshi, you can explain the rationale. Rupanshi, you are
Okay.
not.
Okay.
Now you
So, yes, thank you. So here the question was, when should CPT 59400 be used? First option was when only delivery is provided. Second was when antepartum delivery and the postpartum care are provided by the same provider or the group. Third one is when fewer than 4 antepartum visits are done. And the last option was for cesarean deliveries only. So the correct option was the option B. And maximum 85% of the crowd have voted for this only. Thank you, everyone. Because this answer was correct because it covers all the three services. First one was antepartum, then the delivery, and the last one was postpartum. So the correct option was answer B. Now, moving on to the another CPT, that is 59510. So here is its description and the guidelines. So its description says routine obstetric care, including antepartum care, cesarean delivery, and postpartum care. So how it is different from the earlier CPT, which was at 59400. Over there, it was vaginal delivery, and over here it is cesarean delivery. Now, what are the services which are included in it? Antepartum, then is your cesarean delivery, and the last one is your postpartum care. So CPT code 59510 refers to a global services. The global nature of the 59510 CPT code means all the services performed during maternity cycle are reported and reimbursed together to improve revenue cycle management for healthcare practices. During this process, the physician provides a complete package of routine obstetric care, including antepartum care, that is your prenatal checkups, regular evaluation, and pregnancy long monitoring. Cesarean delivery, which says delivering a baby through an abdominal or a uterine incision. And the third service is postpartum care, after delivery care that usually lasts for 6 weeks. Typically, these services start at 8 to 10 weeks of gestation, include a full term cesarean birth at 39 to 40 weeks of gestation, and normal inpatient and outpatient postpartum care with one or more visits up to 6 weeks after the delivery. Now, when not to code 59510. So, when again, first guideline is when all the components are not provided by the same physician. That is, antepartum, cesarean, and the postpartum are not done by the same physician. Second, care is transferred in or out. Means care has been taken by this provider and some other provider has patient needs to travel some other location, then the care is being taken by some other provider. Vaginal delivery is performed. It's not cesarean delivery, then we are not going to code 59510. Only partial OB care is rendered. A portion of the services are rendered in place of the three services, all three services. So moving on to the case study for 59510. So a 38-year-old obese woman conceives and takes a pregnancy test, which turns out to be a positive. She visits her gynecologist for further treatment. The physician finds out that due to obesity and high blood pressure, this could result in a high-risk pregnancy. The patient needs extra medical care before, during, and again after the birth. The gynecologist provides services from antepartum care to the postpartum to reduce the possibility and severity of the complication. Due to the severity of the case, the physician performed a C-section delivery. Now, see, in this example, antepartum, cesarean delivery, and the postpartum, all three are there. So what should be the CPT code? It is 59510. Hope this is clear to everyone. Moving on to the next slide. So this is CPT 59610. 59610 description is routine obstetric care, including vaginal delivery with or without episiotomy or forceps and postpartum care after previous cesarean delivery. Okay. So CPT 59610 refers to the global maternity package for successful vaginal birth after cesarean. That includes antepartum care, labor and delivery, and the postpartum care. This code is applied when the same provider manages the entire pregnancy through the postpartum care following a prior, prior cesarean section. The purpose of this CPT is basically it avoids splitting services into multiple claims and support continuity of documentation throughout the maternity episode. When we can't report 59610, same provider does not perform all the component, care is transferred in and out, repeat cesarean delivery is performed. And the last, only partial OB care is provided. So let me tell you some inclusion and exclusion of this CPT, that is 59610. So inclusion are comprehensive prenatal visits, hospital admission, labor support, fetal monitoring, episiotomy or forceps use, either one can be used, delivery of fetus and placenta, inpatient postpartum care, and outpatient visits up to 6 weeks after delivery. And what are the exclusions? As I have already told, antepartum only, delivery only, or the postpartum only. So this is a partial OB care and provided separately, and any ultrasound, lab work, or unrelated E&M services done. So to build this CPT, we have a few documentation requirement, that is required prior cesarean history, labor details including monitoring and intervention, hospital discharge date, and postpartum follow-up notes. So moving on to the case study for 59610. Patient 30-year-old with the history of prior cesarean delivery and same OB provider rendered routine antepartum care from 10 weeks gestation through the delivery. What is the visit pattern over here? Visit pattern is monthly to 28 weeks, bi-weekly to 36 weeks, and then weekly until delivery. Successful vaginal birth after cesarean delivery is done at 39 weeks. An infant and placenta delivered vaginally. Episiotomy with first degree laceration repair was performed, and the postpartum care is also done in this case till 6 weeks. So the correct CPT code for this scenario is 59610, as it includes antepartum care, then vaginal birth after cesarean delivery plus postpartum care. Second, episiotomy and routine laceration repair is also included in this global package. Okay, moving on to the next slide. So CPT 59618, it says routine obstetric care including antepartum care, cesarean delivery, and the postpartum care following attempted vaginal delivery after previous cesarean delivery. So 59618 represent a comprehensive maternity care service in which the provider delivers complete antepartum care facilities, hospital admission for delivery, and manages the intensive labor and provides postpartum care. This code applies when patient attempts vaginal delivery after cesarean delivery, but attempt is failed. So this is the difference between 59618 CPT and 59610. Over here, attempt gets failed, resulting in a repeat cesarean delivery. So, typically, global services begin around 8 to 10 weeks of gestation. It includes management through full-term cesarean delivery at 39 to 40 weeks and cover routine postpartum visits for up to 6 weeks after delivery. Now, when we are not supposed to code 59618, provider does not perform all the components, care is transferred in and out, or planned repeat cesarean with no labor attempt. It was already planned, only partial, and to be to make you clear on this statement, planned repeat cesarean with no labor attempted means no vaginal delivery attempt was made over there. So it was already planned. In that case, we are not going to code 59618. Only partial OB care is provided. So here is a case study for 59618. Patient, a 32-year-old G2P1 with a history of one prior cesarean delivery. Prenatal care, same OB provider rendered routine antepartum care throughout pregnancy. Labor attempt, patient elected trial of labor after cesarean at 39 weeks. Delivery, labor failed to progress, converted into a cesarean delivery. Infant delivered via abdominal and uterine incision. Placenta was removed, uterus and abdomen closed with the sutures. Postpartum care was also provided. Now, this is the accurate scenario for 59618. Now comes antepartum care, which says which has a CPT 59425 and 59426. So in this, we have a distinction between these two CPT on the basis of number of visits. So 59425 says 4 to 6 antepartum visits only. Beyond 6, it will move on to the CPT code 59426. That is 7 or more visits. So less than 4 visits, we are not going to bill with these CPTs. We are going to bill individual E&M codes. So here is a CPT 59425, which says antepartum care only, that is up to 4 to 6 visits. So guidelines are, what are the services included in this? Prenatal visits related to normal pregnancy, history and physical examination, monitoring of weight, blood pressure, and fetal heart rules. Routine chemical urinalysis covers 4 to 6 prenatal visits. When we are not supposed to code 59425, when fewer than 4 prenatal visits are there, we need to code individual E&M codes. Delivery and postpartum care are also provided. Then we are not supposed to code 59422 or 59425. We are going to code global OB codes. Complete antepartum care, that is 7 or more visits. In this case, we are going to code next CPT, which is 59426. So here is a case study for 59425. A 25-year-old woman starts her maternity care at the 5th week of gestation. She visits her OB-GYN every month. However, after the fifth visit, she has to relocate to another state to her husband's job. Hence, she also transfer care to another provider. Obviously, she is means moving on to the next new location, so she will be referring to the another provider over there. On other hand, bill those 5 office visit with the CPT code 59425. Is it clear? Like she has to relocate for her husband's job, hence her care is being transferred to the another provider. It's Dr. Zina. So in this case, will those 5 office visits, we are having 4 to 5 office visits which are included in this CPT. So it will be coded as 59425. Moving on to the next CPT, that is 59426. Description of 59426 says antepartum care only, that is 7 or more visits. So CPT code 59426 covered 7 or more antepartum encounter. It is basically we can say mini global code that identifies a reduced service portion of the global code 59400. So this may be a circumstances that lead to the patient transferring out of the practice before delivery or the pregnancy, like we had an example in 59425, terminating before delivery. In such cases, OB-GYN does not perform all of the antepartum care. However, he may perform the delivery with or without postpartum care when the patient transfers in from another practice. When any of those scenarios occur, you cannot report basically 59400, which is a entire global package. Over there, all 3 services should be there. So it basically includes prenatal care related to the normal pregnancy, initial and subsequent history and physical examination, monitoring of weight, blood pressure, and fetal heart tones, routine chemical urinalysis, and the covers 7 or more prenatal visits. Now, when we can't code 59426, when we have fewer than 7 prenatal visits, we need to provide which CPD? 59425, which is for 4 to 6. Again, reminding you that if we have less than 4 visits, then we need to code a separate TNM. Delivery and postpartum care are also performed. Report appropriate global OB code because a complete package will be there. Only 1 to 3 visits are provided. Report individually in codes. Here is a case study for 59426. So 59426 example says a OB-GYN Dr. John who rendered comprehensive prenatal care to the patient for the majority of her pregnancy. The documentation supports total of 10 routine antepartum visits from week 8 through week 35. However, the patient has to relocate immediately to a different city due to a job change. As a result, her care is again transferred to a new OB-GYN, that is Dr. Sarah, for the remainder of the pregnancy and delivery. To report such a scenario, we have to code 59426, which says for the 10 antepartum encounters, as the entire antepartum, postpartum, and delivery was not there. Only what we are having over here, as in to code 10 antepartum encounters visits. Okay, so the CPT 59426 needs to be coded. Hope this CPTs are clear to everyone now. So I'm moving on to the poll question. Uh, should I publish this result? Srinivas? Prashad?
Yeah, you can back to list. You can click on back to list.
Okay.
Yeah.
So I'm sharing the poll question.
This session has been arranged based on the interest and request you shared with us during the previous session. So we would really appreciate your active participation in today's polls as it helps us understand your perspective. But we do see less percentage of people are responding to the poll. We do see only 19% of people responded to this poll question. So I request everyone to be attentive and respond to the polls on time. Rupanji, allow them one more minute. Then you can read the results and you can continue the session.
Sure, ma'am. Okay. Okay, so I can see 80, how much? Yes, 81% crowd have answered 59426. Okay, so it was your poll question. A patient has eight routine prenatal visits and delivers with different provider. So which CPT is the correct to quote? 59425, 59426, 59400, and 99213. So the correct option was 59426, and 81 coders have attempted the correct. Basically, the difference between 59425 and 426 is on the number of the visits. 59425 says when the visits are less than 7. 5946. And when visits are more than 7, which was 8, hence we need to code 59426. Okay. Moving on to the next slide. So here is a slide focusing on what are the services which are included in the antepartum services. Basically a routine prenatal visit, routine counseling, then the BP, blood pressure and the weight monitoring and the fetal checkups, that is fundal height and fetal heart rate checks. Now we have delivery coding, that is vaginal. So 59409, 59410. 59409 is basically delivery only, and 59410 is delivery plus postpartum care. So here is a CPT 59409. Now let's discuss this CPT. Its description says antepartum care only and 7 or more visits. So basically, CPT 59409 is only for vaginal delivery services. You cannot bill global services under this code. This code is only applicable in case of emergency delivery by another physician. Comprehensive, basically what record should be there to accurate code this 59409. So comprehensive notes on hospital admission and labor should be there. Procedure conducted, that is episiotomy, forceps or vacuum assistance. Timing of delivery and management of the placenta. Documentation of laceration repair. Confirmation of antepartum and postpartum care provided in another setting. The date of vaginal delivery and the confirmation that the fetus and placenta were delivered on the same date of service. So, it includes vaginal delivery of infant and placenta, episiotomy if performed, repair of first and second degree laceration, not included antepartum care and the postpartum care. When to report 59409? When provider performs delivery only, no antepartum, no postpartum. Prenatal and or postpartum care was provided by another provider, not performed by the current billing provider. So, what are the takeaway for this CPT? CPT code 59409 bills for vaginal delivery only, including those with or without episiotomy or low forceps. However, we cannot cover postpartum care in this code. Moving on to the case study for 59409. Now, a woman who is in her last trimester and expecting to deliver in few days. Despite having a later date, she experiences an unexpected nighttime labor. In this emergency, her physician is not available on call. So another physician who is on duty and overseeing other patients performs the vaginal delivery. Since the on-duty obstetrician did not offer prenatal or postnatal care, so how we will code this? We will only code the vaginal delivery. That is 59409. Because this physician is only giving service for the vaginal delivery. Okay. Hope this is also clear. So moving on to 59410. Now, 59410 says vaginal delivery only, with or without episiotomy and or forceps, including postpartum care. So here is a difference. Over there, only vaginal delivery was there, and in this, including postpartum care is also there. So 59410 is used for vaginal delivery, including antepartum and postpartum care, encompassing the labor management, delivery, and the follow-up care for the mother. So, overview for this CPT, we can say 59410 is a global obstetric code that covers a full spectrum care of a vaginal delivery. So it monitors labor progression, fetal heart rate, and we have done already interventions such as induction of labor if necessary, delivery procedure, vaginal delivery of the baby, and placenta, which may include ostomy or forceps assistance or even the vacuum one. Postpartum care, inpatient and outpatient follow-up care for the mother, typically up to 6 weeks. I'm again and again repeating typically up to 6 weeks because this is the duration for the postpartum care. So this term is basically intended the full-term pregnancy without contraindications for vaginal delivery, where labor progresses naturally or with minor assistance. It is commonly performed in hospital or birthing centers by obstetricians, midwives, or the delivery team. So 59410 is used when the physician provides routine obstetric care throughout pregnancy, delivery, and postpartum recovery. The code ensures comprehensive maternal care, including pain management, fetal monitoring, and recovery support. It is basically differ from 59409 or cesarean delivery 59510. So when to report 59410? Provider performs delivery plus the postpartum prenatal care was also provided by another physician, not performed by the billing provider. Moving on to the cesarean CPTs, that is 59514 and 59515. 59514 says cesarean delivery only, that is cesarean delivery of infant, removal of placenta, closure of uterine and abdominal incision. Services not included are antepartum care and the postpartum care. So basically, CPT code 59514 represents the cesarean delivery only. The healthcare provider performs the delivery of the fetus and the placenta throughout a surgical incision in the abdomen and offers immediate post-delivery care on the same day. It excludes both antepartum and the postpartum care. So any services provided during the pregnancy or after the first day of the delivery until 6 weeks are not covered by this code. So when not to report CPT 59514, basically provider performed antepartum delivery and postpartum. So we have a global code 59510. Then provider performs cesarean delivery plus postpartum care. Then we have CPT 59515. Provider also provided antepartum care. Then also we can't code 59514. Care was not limited to delivery only. Another cesarean specific global or partial OB code applies. Delivery was vaginal with or without assistance. In that case also we can't code 59514. Now here comes the description for the another CPT that says 59515, which says cesarean delivery only including the postpartum care. So this includes basically services which are included in this. Used for cesarean delivery with routine postpartum care includes preoperative evaluation, surgical delivery, and standard postpartum follow-up. Excludes antepartum, that is prenatal care. Bill separately if performed. Report once per delivery regardless of single multiple gestation. Requires documentation of indication for cesarean and postpartum management. So basically, the purpose of the CPT 59515 requires through the documentation that captures the full scope of cesarean delivery and associated postpartum care. First of all, what are the elements we need to check for the CPT? is the gestational age at delivery, including whether the pregnancy is first time or subsequent and the trimester, any complication during pregnancy or delivery, along with risk factors such as advanced maternal age, poor prenatal history, or pre-existing conditions like hypertension, diabetes, or anemia. Diagnosis, very important for the medical necessity and management of the gestational diabetes, including whether it was controlled by or diet or required insulin, fetal condition. Then the inpatient admission details, including gestational age at the admission, complication during hospital stay, and delivery specified such as type of or the number of fetuses and the outcomes. And at the last, the exact location of delivery, whether in hospital, birth center, or the another setting. So all postpartum care provided, including inpatient recovery and the outpatient visit, typically extended up to 6 weeks after delivery. A clear statement confirming that the provider both performed the cesarean delivery and managed the postpartum care to justify so that we can use 59515. So clear documentation should be there to code 59515, which says cesarean delivery was performed and also postpartum care was given by the same provider. So when we can't code 59515, again, when we have all three services which comes under the global OB code, that is antepartum, delivery, and postpartum services are built. So in that case, we are not going to code 59515. Then do not report when billing cesarean delivery only. For that, we have a specific code 59514 without routine postpartum care. Do not report for vaginal deliveries or failed cesarean attempts resulting in vaginal birth. In that case also 59515 won't be coded. Then do not report if postpartum care is incomplete or transferred to another provider. Next is do not report with other cesarean delivery CPT codes for the same pregnancy. Last, do not report if the documentation does not support routine postpartum services. So to report 59515, we should be having a clear documentation of the delivery, which is a cesarean, and the postpartum care is being provided. A very clear documentation should be there to code the CPT 515. So here is a case study for 59515. A patient at 39 weeks gestation undergoes a repeat cesarean delivery. Preoperative evaluation performed on the day of surgery. Routine postpartum care was provided by the same obstetrician. Antepartum care performed by a different provider. Now, see, it is very clear that postpartum care and the delivery is being done by this provider. Hence, we need to code CPT 59515 for such scenarios. Moving on to the next CPT. So this is VBAC and complex deliveries, which says vaginal delivery after previous cesarean delivery. So here are the CPTs 59612, 59614, 59620, or 59622. I'm going to deep dive in these CPTs. 59612, the first one. So 59612 is a CPT which says vaginal delivery only after previous cesarean delivery without episiotomy or forceps. Vaginal delivery can be by means like it can accompany with any of the method to ease the delivery, episiotomy or forceps, but previous history of cesarean delivery should be there. So what are the services included in this CPT is vaginal delivery of infant after prior cesarean section, delivery of placenta, episiotomy if performed, repair of first and second degree laceration. Services which are not included is the antepartum, prenatal care, and the postpartum. Now, here are the guidelines when we cannot report 59612. Provider perform antepartum, delivery, and postpartum. So, we have already introduced ourselves to the code 59610. That is a global package CPT code which includes all three. So over here, what the scenario is, it is only vaginal delivery, no antepartum, no postpartum, but has a history of cesarean delivery. Now, next, when we cannot use it, provider perform vaginal delivery after, before a cesarean history is there. So plus postpartum care. So I've already told if any of them are included, antepartum or postpartum, we are not going to code. So for that, we have 59614. Provider also provided antepartum care. Again, this 59612 disqualify. We will be only coding this code when we have vaginal delivery only without any of these antepartum or postpartum. Delivery resulted in a cesarean section. So earlier patient has a history of cesarean section, cesarean delivery. Over now she was trying to deliver a baby vaginally, but again vaginal delivery failed. Now cesarean delivery is there. So in this case also we cannot code 59612. Okay. Then delivery was planned or repeat cesarean with no vaginal delivery. Then also we are not supposed to code 59612. Delivery was a primary vaginal delivery with no prior history of cesarean delivery. So if no prior history is there of cesarean delivery, then also we cannot code 59612. So here is an example of 59612. Suppose there is a patient, Sarah, with a history of previous cesarean delivery, arrives at the hospital for a planned vaginal delivery. However, the labor turns out to be challenging with prolonged contraction and potential fetal distress. The attending physician, Dr. Smith, carefully monitors Sarah's progress and performs multiple vaginal examinations to assess dilation and fetal position, and manages the labor with medication and specialized monitoring techniques. Due to the increased labor management complexity and fetal distress, Dr. Smith utilizes low forceps to deliver the baby. So forceps help was utilized over there to deliver the baby. So what should be the code to code such a scenario? So basically, earlier has a history of a cesarean. Now the baby is delivered how? Vaginally. So the correct CPT is 59612. And you need not to confuse like forceps for utilize. I have already cleared that forceps or episiotomy can be used in this to ease the vaginal delivery. Okay. Now we can take another example. Let me give you another example to when we can code 59612. Now, suppose Jessica is there and we are delivering a healthy baby vaginally after a previous cesarean delivery. Her delivery was uncomplicated and required no specific interventions or interventions like episiotomy or forceps. And the postpartum period, however, required routine care involving blood pressure checkups, monitoring her recovery, providing breastfeeding supports, and everything. But only provided the provider only provided the delivery that was done vaginally. So for this scenario, again, what will be coded? You can give answer in the chat box, please. So they are able to write in the chat box.
Yes, Rupanshi, everyone writing. Just you click on the all point, not organizers. Okay.
Okay. I'm so sorry. Huh. Yes, the correct answer is 59612, as no postpartum care was given. But now I'm moving on to the CPT 59614, which is basically vaginal delivery only after previous cesarean delivery, with or without episiotomy and or forceps, including the postpartum care. Now, how this CPT is different from the earlier one? Earlier CPT was 59612, which says only vaginal delivery. But here, vaginal delivery is also there with a history of cesarean delivery, but also includes postpartum care. Okay. So 59614 is used for vaginal delivery after previous cesarean section, that is VBAC, included antepartum delivery, not but the postpartum care. So labor and delivery is also included in this, that is hospital admission, continuous fetal monitoring, management of labor, vaginal delivery of the infant, delivery of the placenta, and any necessary intervention such as episiotomy, forceps, or vacuum extraction. Then comes your postpartum care. Inpatient and outpatient care for the mother and newborn, including monitoring for complications and ensuring maternal recovery. So, what should be the documentation requirement to code such scenarios? A detailed documentation should be there for the vaginal delivery and with the history of previous cesarean delivery, including the postpartum delivery documentation. So, services included is successfully vaginal delivery after prior cesarean, delivery of infant and the placenta. It might be used episiotomy if performed, repair of first and second degree laceration, postpartum care, hospital follow-up visits, and the postpartum office visits, typically up to 6 weeks. So, services which are not included are antepartum care. When not to report 59610, when antepartum, delivery, and postpartum, all three services are given, then what we are going to code? 59610. Next is VBAC. What does it say? Vaginal delivery after a previous cesarean section. Only. No postpartum is there. And recently we have introduced ourselves to the CPT 59612. So if no postpartum care is there, then we need not to code 59614. Provider also perform prenatal care. Then again, we are not going to code the CPT. Failed VBAC, cesarean delivery performed. No prior history of cesarean delivery was there. Then also we are not going to code 59614. Okay, moving on to our next CPT, that is 59620 and 59622. So first I'm going to cover 59620, which says cesarean delivery following attempted vaginal delivery after previous cesarean delivery. So CPT code 59620 is specifically designed for a situation described where a cesarean delivery is performed after an attempt at a vaginal birth following a previous, that is a history of cesarean delivery. So description of 59620 says 59620 cesarean delivery only following attempted vaginal delivery after previous cesarean delivery. Delivery type is again cesarean. Postpartum care is not included. What it covers? Delivery only after failed BBC. Okay. Now, if I compare the CPT to 59622, this says over here 620 was only for the attempted vaginal delivery after previous cesarean delivery, but this says cesarean delivery only following attempted vaginal delivery after previous cesarean history of cesarean delivery, but it includes the postpartum care. So in 620, no postpartum care is included, wherein in 622, postpartum care is also included. So the delivery type is cesarean. Basically, it covers delivery plus the postpartum care. So let me give you a scenario. You all can answer me in the chat box. Okay. So suppose Sarah arrives at the hospital with labor pains. She had a previous cesarean delivery, C-section, okay, and is hoping for a vaginal birth this time. The doctor monitors Sarah throughout the labor and ready for the any complication. The doctor is alert. Okay. So, however, despite the best effort, complication arises. And at the end, what happens? A cesarean delivery becomes necessary to ensure the safety for both mother and child. So, patient has a history of cesarean. Okay. And here, vaginal birth is failing. Okay. And now they are delivering the baby through the C-sec. So, how we will code this situation? Let me show you this slide as well. And no postpartum care is there. So how you will be coding this scenario? Great. Yes. The answer is correct, 59620. And again, if I change the situation, if I say now Sarah was trying for the vaginal birth, but she failed due to some complication. Then the complication led to the cesarean delivery, and now the postpartum care is also provided by the same provider. So how you will be coding this case? All of you, please reply. Then how you will code this case when postpartum care is also included? Great. So as I'm getting the correct answers, so I think now the CPTs are clear to you. Okay, moving on to the next slide, which says postpartum care. What does it includes? Covers evaluation after delivery, includes pelvic pain examination, counseling related to mother, how means what are the things mothers are getting in, what are the problems they are facing. So everything is being covered in the postpartum care, reported separately using 59430 if it is outside the global codes. Okay, now I've taken a lot of time for this session. Okay, let's have a quick icebreaker question over here. And I need an answer from all 3000 members, please, all of you.
So guys, don't need any subject expertise to respond to this icebreaker. Just share your thoughts and participate to the session.
Poll questions were having less number of voters. I mean, the more number of the voters rather than icebreaker.
Yeah. Yeah, fine. Manjeet. So, majority
Uh,
of us, they need coffee now. So, they need a small break. No problem. We'll give them 2 minutes to go for a break.
okay, sure.
Meanwhile, you can grab your coffee. Then we will continue the session.
Okay,
We will resume the session by 11:25.
okay.
Yeah.
Thank you.
Okay. We can resume the session.
Okay, okay, ma'am.
Thank you, Rupanji.
Now we have the codes for obstetric ultrasound coding. So we have four codes basically: 76801, 76805, 76811, and 76817. So 76801 So the CPT code 76801 is from the diagnostic ultrasound procedure of the pelvis obstetrical code range. The code reports the live imaging of a pregnant uterus using a transabdominal approach. Providers primarily order this diagnostic test to examine first or a single fetus and the mother during the first trimester, which is less than 14 weeks of pregnancy. So basically, these are the services which include report for a transabdominal obstetric ultrasound in the first trimester, used to confirm intrauterine pregnancy, gestational age, fetal number, and the viability. Applies to single gestation only, multiple gestations code separately. Includes evaluation of uterus, adnexa, and fetal anatomy appropriate to the gestational age. Typically reported for the initial prenatal ultrasound when medically indicated. Documentation must include gestational age, findings, and clinical indications. So, here is a case study for 76801 CPT. This says a 30-year-old female patient with a delayed menstrual period and a positive home pregnancy test visiting the OB-GYN clinic. Her last menstrual period was 8 weeks ago. Thus, she wants to confirm viability of the intrauterine pregnancy. So the gynecologist orders a transabdominal ultrasound, that is CPT 76801, to visualize the gestational sac, yolk sac, and the fetal pole with the detectable heartbeat. Okay, giving you another example for this CPT. Suppose a 28-year female who is 11-week pregnant, visiting the emergency room with a mild abdominal cramps and vaginal bleeding. The healthcare provider performs a transvaginal ultrasound to assess the pregnancy. The ultrasound reveals a single intrauterine pregnancy with a fetal heartbeat is there. Okay, fetal heartbeat is present. The provider further evaluates the gestational sac and the fetal size. Besides, he surveys for any evidence of subchorionic hemorrhage or other potential cause of the bleeding. So, what should be the CPT code for this scenario? I am saying it is a transabdominal approach. It is not transvaginal. So for transabdominal approach, we need to code 76801. Okay. Now moving on to the code 76805. So basically 76805 says ultrasound pregnant uterus, real time with image documentation, fetal and maternal evaluation after first trimester, greater than or equal to 14 weeks, transabdominal approach, single or first gestation. So services which are included in this are report for transabdominal obstetric ultrasound performed after 14 weeks of gestation, used for detailed fetal anatomic survey and pregnancy evaluation, applies to single gestation only. Multiple gestations are not reported in this code. Includes assessment of fetal anatomy, placenta, amniotic fluid, and maternal structure. Typically reported for the initial comprehensive second or third trimester ultrasound documentation. that must support gestational age, medical indication, and complete finding. So let me tell you what are the how we can say a complete second or third trimester transabdominal ultrasound is defined. So determination of number of fetuses and amniotic or the chronic sacs, measurement of appropriate for gestational age, survey of intracranial or spinal or abdominal anatomy, four chambered heart should be there, umbilical cord insertion site should be there, placenta location, what is the actual position statement, not just the normal or abnormal. Okay. Next is the amniotic fluid assessment, qualitative or quantitative should be mentioned, examination of maternal adnexa, ovaries, tubes, uterine ligaments when visible. If if in case the maternal adnexa are not visible, so the document should basically describe in the report that why it is not visible. And in case if one or more specific anatomic structure is not visible during the procedure, a generic statement in the dictation should be there, such as no abnormality seen in this uterus or endometrium. That would also satisfy the requirements of reporting the maternal uterus and the adnexa. Okay. Okay. Now I'm moving on to the CPT 76811. So its description says, sorry, ultrasound pregnant uterus real time with image documentation, fetal and maternal evaluation plus detailed fetal anatomic examination, that too transabdominal approach, single or first gestation. So report for detailed anatomic fetal evaluation after the first trimester, used when increased risk of fetal anomaly is identified or suspected, includes comprehensive assessment of fetal anatomy, organs, and measurable structures, applies to single gestation only. Use additional codes for multiple gestation. Not reported routinely, requires medical indication beyond standard ultrasound documentation, and must support risk factors, gestational age, and detailed finding. And for each gestation we need to add 76812. It is an add-on code. So CPT codes 76811 and 76812 include all elements required for routine complete OB ultrasound plus an extensive evaluation of fetal anatomy. So the basically the elements which I have told you for 76805, that elements plus the extensive evaluation of fetal anatomy should be there to report 76811. Like what should be there? Like fetal brain, ventricles, face, heart or outflow tracts, chest anatomy, abdominal organ specific anatomy, number or length, architectures of limbs, umbilical cord and placenta, other fetal anatomy as clinically indicated. Okay, let me show you one case study for this 76811. Okay, so a 29-year-old patient at 22 weeks gestation is referred for a detailed fetal anatomic survey after a routine screening ultrasound suggested possible cardiac asymmetry. So the approach is transabdominal, it is very clear. So fetal evaluation says head, brain structure, face, spine, heart, that is four chamber view, outflow tracts, abdomen, that is stomach, kidneys, bladder, cord insertion are visualized, limbs, extremities, placenta location and cord vessels, amniotic fluid volume, everything is mentioned. Then maternal evaluation, cervix length is there, uterine and adnexal structures are there. All structures visualized and within normal limits. No anomalies detected. So this is an example where we can code 76811. So how it is different from the CPT 76805 and 76811? Because 805 says determination of number of fetuses and amniotic sac, measurement of the gestational age, okay, amniotic fluid assessment. But over here we have a detailed fetal anatomy, that is fetal brain, ventricles, face, heart, inflow, outflow, chest anatomy, abdominal organ specific anatomy, number and length, architecture of limbs, umbilical cord and placenta, and other as described, cervix length and all. So hence we can code for this scenario, we can code 76811. Here comes 76817. So in the chat, I saw the code 76817. So let me make you very clear for this code as well. This is a basically a transvaginal approach code. So ultrasound pregnant uterus real time with the image documentation, and approach should be a transvaginal. So report for transvaginal obstetric ultrasound at any gestational age when clinically indicate, used to evaluate early pregnancy, cervical length, placenta or fetal anatomy. May be performed alone or adjacent with the transabdominal ultrasound. Both can be done. Means transabdominal ultrasound can be done and also transvaginal ultrasound can be done. Both can be done and we can code both the reports. Okay. Next is not limited by trimester. Medically necessity must be documented. Report once per session. Documentation must include indication approach. Approach should be very clearly mentioned that transvaginal approach is their gestational age. And again, as per the approach, as per the technique, finding should be supportive. It's not like that means it shouldn't be not it shouldn't be there like approach is transvaginal, but the findings are not getting correlated with it. So approach and finding should be correlated. So code 76817 is used to report an OB ultrasound exam performed with a transducer position in the vagina. Basically, it is reported once per study, regardless of the number of the fetus, and includes evaluation of embryo, gestational sac, maternal uterus, adnexa, and or cervix. This code does not require fetal measurement, basically, since the transvaginal field of view is limited. So the code for transvaginal ultrasound is 76817. I'm sorry. So Sarah is a 32-year-old pregnant woman, 10 weeks pregnant. She visits a physician for her first prenatal ultrasound. The encounter is basically the ultrasound technician performs a transvaginal ultrasound using the appropriate probe and imaging techniques, acquiring clear picture of Sarah uterus and developing fetus. She performs all required assessments, including the size and position of the fetus, and gathers all the information, important data to help determine Sarah's gestational age. The technician creates a complete and detailed ultrasound report, including the imaging data, measurement, and overall assessment of the fetus health. So here the approach is very clearly given, transvaginal approach, and the findings is also for the uterus rather than the transabdominal finding. So it is the example to code 76817. So here we have 4 codes for fetus surveillance codes. Basically 59025, non-stress testing, 59020 contraction stress test, 59000 amniocentesis, 59015 chronic venous sampling. So, CPT code 59025. Here's the description which says fetal non-stress test, which includes report for antepartum fetal non-stress testing with monitoring and interpretation, requires medical necessity. That why this test is being performed, high risk pregnancy, decreased fetal movement, includes fetal heart rate monitoring and physician interpretation, may be reported once per date of service, pair frequency limits apply. Obviously, not reported during labor or at delivery. Antepartum use only. The CPT is purely used for the antepartum visits. Documentation must support gestational age, indication, results, and interpretation. So the CPT code for fetal non-stress test is 59025. I'm not able to click on the poll. Yes, it's coming now. Mhm. Okay, let me give you one case. You can reply in the chat box. So, pregnant patient at 34 weeks of gestation present with decreased fetal movements. Provider perform a fetal non-stress test (NST) in the office, and test is reactive and documented with interpretation. No delivery performed that day. So, how you will code that case? If fetal non-stress test is being performed and delivery is not performed on the delivery is not done on that day, please reply in the chat box. Yes, great. So 59025. Okay. 59020, next CPT, which is fetal contraction stress test. So report for antepartum fetal contraction stress testing evaluates fetal heart rate response to include uterine contraction stimulations, monitoring and interpretation, used when assessment beyond a non-stress test is clinically indicated. Report once per date of service. Documentation must include gestational age, indication, test method, and interpretation. After that, we have 59000, that is amniocentesis diagnostic. Report for antepartum diagnostic amniocentesis used to obtain amniotic fluid for fetal evaluation for genetic or lung maturity testing. Applies when the procedure is performed transabdominally under appropriate guidance. This is also reported once per procedure. Diagnostic intent must be documented. Separate reportable from routine prenatal care not included in the global OB packages. If it is done, then it has to be reported separately. Documentation must support gestational age, medical indication, and procedure details. Then another CPT we have 59015, which is craniovenous sampling any method by any method. So what are the services included in report for antepartum transabdominal chronic venous sampling CVS used for early prenatal genetic or chromosomal evaluation, includes sampling procedure and physician work. Imaging guidance reported separately if applicable, typically performed in the first trimester when medically indicated. It has to be done in the first trimester itself. It can't be go beyond that. Report once per procedure regardless of number of samples obtained. Documentation must include gestational age, indication, approach and findings. So we have done with the CPT codes. Now moving on to few of the ICD rules for OB and gynae coding. So key rules: use exclusively during pregnancy, childbirth, and the puerperium. Codes differ from antepartum, delivery, and postpartum. OB codes must always be sequenced first. Additionally, codes may be described specific condition or the complication. Here comes the pregnancy trimester. So first trimester, which is less than 14 weeks. Second trimester, which is 14 to 28 weeks. Third trimester is greater than 28 weeks. Trimester must be clearly documented in the medical record. If it is not documented, then we have to take it as not defined, unspecified, basically. Moving on to the next slide that says how week of gestation are divided into the months. So first trimester covers the first month, second month, and the third month. That is a number of the weeks till 1 to 13. Then we have second trimester, then the fourth, fifth, and sixth, which covers from 14 to 27 weeks. Third trimester covers 7, 8, and 9 months, which is 28 weeks to 40 weeks. So okay, I have shared the poll. Please answer this question. All of you, please check the options. First two options are a bit confusing. One is Z34 and one is Z3A. So maximum of you have given the correct answer. This is the correct option is B, Z3A, XX. Now comes your high risk pregnancy coding. O09 category used during prenatal periods. Example, advanced maternal age, IVF. Do not use during delivery episode. So causes of high risk pregnancies are late pregnancy, weight, multiple babies, health condition, pregnancy related issues, previous consecutive abortions. Moving on to the diabetes in pregnancy, O24 category, specified type, which type of diabetes is there, gestational or the pre-existing, never code multiple O24 codes, category codes together. All of you, please answer the poll question. A patient is diagnosed with the diet control gestational diabetes. Okay. So a patient is diagnosed with diet control and diet control gestational diabetes. So the correct option was O24.410. Maximum coders have attempted the correct answer. Now comes your hypertension is in pregnancy. So if pre-existing hypertension complicating pregnancy, we need to go for the series O10. Then we have O13 to O16, that is gestational hypertension and preeclampsia. Additional manifestation codes may be required, for example, heart failure, renal involvement, or other complication. Next is normal delivery coding. O80 only for uncomplicated full-term delivery. No antepartum or intrapartum complications allowed. Outcome of delivery code, that is Z37, is required. Here are few OB coding rules and sequencing. So OB condition should always be sequenced first. Avoid unspecified codes. Document fetus number when applicable. Okay, all of you please vote for the poll. So the question was, which ICD-10 chapter is used for pregnancy related condition? That is O series. Correct answer is option C. Modifier commonly used, modifier 24, that is unrelated ENM. 22 is for increased services and 59 is for the distinct procedural service. So when unrelated ENM condition is there, we need to code modifier 24.
And if these services has been taken a bit more time rather than the what was required, increase in the timing, then we need to code modify 22. And if the two different procedures are performed of the same site, means on the same site, then we need to code 59 procedure 59 modifier. Great. Most of you have voted for modifier 24. So that was the correct answer. So it is modifier 24 is the correct option. Now, abuse and special situations. O9A codes for abuse during pregnancy. If it is applicable in your client, then we can add the external cause and the injury codes and follow the strict sequencing rules. As external cause can never be PDX and O series has to be always in the PDX. So next we have documentation best practice. Clearly document trimester and gestational age should be there. We can even raise IRs or we can raise the queries. We can connect with the clients to improve the documentation. Then indicate complications and risk factor. Ensure procedure notes support CPT build. Whatever the CPTs we are coding, it has to be very relevant with respect to our medical records. Common coding errors. Unbundling global OB services. We need to check the entire medical record. It is getting covered under the global package or not? Is it only the separately billed CPT? Missing Z3A codes. It has to be there with every case when OCD's codes are being added. Incorrect trimester selection. We have to be very clear concept with the trimester. Hope now everyone knows how to calculate the trimester as well. Next is the billing routine and the coding routine visit separately. So here are a few key compliance tips. Follow CMS and payer specific rules. Audit charts periodically. Educate providers on the documentation if it is impacting our payment rate. So to reduce the denial rate, even we can request the providers also through the proper channels. Okay, let's have few poll questions at the end now. So here is the question. When can ICD-10 code 080 be reported? Great. Good. Okay, so the correct answer was full term uncomplicated delivery only. Okay, moving on to the next question. Read the question very carefully, all of you, please. Postpartum care is also there. So, maximum all of you have coded for 59612. This is not the correct option. It has to be 59614, which says vaginal delivery after a previous cesarean section, including the postpartum care. So in 59614, postpartum care is also included, whereas 59612, it does not include the postpartum care. Okay. Next question we have. Okay, so I'm just giving you a question you can write down in the chat box. When CPT code represent global vaginal delivery? Which CPT code? Global vaginal delivery. I'm not saying any history or so. It is just global vaginal delivery. Very good. Great. Okay. Here is the another poll question. This we have done. Okay. Okay. So that's all for all the poll questions. Moving back to our takeaways. So, why accurate OB coding matters? So, the first and foremost reason is ensures proper reimbursement, reduce denials and audits, supports high quality patient records. How to think, not memorize, use logic and documentation, not just to memorize. Review the complete clinical picture. Always ask same provider or the different provider, how many visits occurred, are there any complication documented or not. Next is key OB rules. So the first one is OB-ICD-10 codes that has to be there from the O chapter series, which has to be sequenced first. Z3A codes, that is week of gestation, and O80 series when there is no complications. So winding up the session, basically we are the coders. We can basically enhance the reimbursement, and we are the coders who are responsible to reduce the denial rates as well. So hope these concepts will help you a lot in the coding of OB and gynae cases. Thank you. Any questions, please?
Yeah, thank you, Rupanshi. We have some questions from the coders and also. The first question is, am I audible, Rupanshi?
Yes.
Yeah, Prasad, you're audible, yeah.
Yeah, the first question from coders hand. Third degree laceration repair, how we will bill along with 59400. I'm repeating a question again. Third degree laceration repair, how we will bill along with 59400. Rupansha, are you clear with the question?
Hello.
Yeah, Rupanshi, am I audible?
Yes, you are audible. Please, just repeat the question.
Yeah, again. Third degree laceration repair. It is
Yes.
a third degree laceration repair.
Mm-hmm.
How we will bill along with 59400.
Okay, because first and second degree laceration repair is already included. So basically, we need to code it separately for this code.
Okay, thank you.
And the repair code should be there. Laceration repair code should be there.
Okay, we have to code the additionally, right?
Yes.
Yeah, thank you. The second question is from the coders end. So, what is patient had 3 pregnancies? The first is C-section, second is vaginal, and third also vaginal. Here for the third delivery, here patient came for the third delivery. Can we code VBAC for vaginal delivery? VBAC
Yes.
or vaginal delivery?
So if a patient has a history of cesarean delivery, then we will go with that case, because she has a history of cesarean delivery, then we have the case for the cesarean history.
Thank you. Thank you, Rupanshi. These questions are from coders end. We received.
Okay.
Thank you for the answer. Srinivas, over to you.
Okay, so do we have any other questions, Prasad? I think are we good, right?
Yes, Srinivas.
Okay, great. So I think so we are going to conclude this session. So I think we have 2558. So okay, Rupanshi, such a wonderful session, and I'd like to thank you from the bottom of my heart, because OB-GYN is always a difficult subject to deal with. So definitely thanks to you, and thanks to all the participants who have been patiently hearing and responding. So this was such a interactive session. So I'd like to thank you everyone. Special thanks to Rupanshi. Thank you so much for taking your time. Give your valuable insights into the OB-GYN. Which is again a topic of concern for most of the people, including myself. So I was patiently listening to you, which was wonderful session. So that is the thing. And we'd like to thank the ABC local chapter Hyderabad, uh, starting from President Adilakshmi ma'am, who's not here due to some preoccupied things, and Harish, Sri Madhuri, Prasad, and myself. So thank you so much for connecting such a wonderful session. And uh, that's from me. Rupanshi, would like to add anything at the end?
Yes, thanks to everyone who was directly or indirectly involved to give me this opportunity, and thanks to all the coders who were there, who were bearing with me, who were really listening to me and responding to my questions, and again getting their concept clear. Thank you,
Okay,
everyone.
so I'd like to add two more points at the end. Rupanshi, thank you so much. That
Mhm.
regarding CEUs, guys, I'd like to provide an update. It will take at least 3 weeks time from today. It is 18th of April. So we would take at least 3 weeks to credit your CEUs. So don't be in a hurry. And I'd like to mention this thing again and again. I've seen a lot of personal details in terms of the member IDs and all, so which we are not expecting from you because the registration is done. We have the details of yours. The second thing, if there is anything that you want to know from us, uh, please reach out to us on WhatsApp channel, that is ABC Local Chapter Hyderabad, and we are also active on LinkedIn, which we are going to regularly keep in touch with you. And any other forum, you have my number as well, so please reach out. So before we conclude, again, I'd like to thank everyone. On Saturday morning, you have spent 2 hours of time, valuable time, obviously. So have a good day, good weekend. Have a blast. Thank you so much, everyone. Thank you. Take care. Bye bye.
Thank you, everyone.
Thank you all for attending this session.